joining the Alzheimer's Advocacy Academy. This is episode 8. We've been doing these for 2 months now. My name is James Fitzpatrick, and I am the Director of Public Policy and Advocacy at the Desert Southwest chapter, serving Arizona and Southern Nevada. Right now, we have advocates from Arizona, Nevada, Hawaii, and California joining us today. And I just want to remind you guys that we do have an amazing policy staff that is helping us run these advocacy academies, as well as facilitating all of the amazing work that you guys do advocating. I do want to give a shout out to Nicole Dowski, who has been the moderator for our academies, but she is now on maternity leave. So please give her and baby Dowski some good thoughts. Today's topic is facts and figures and Griffis data sources. We have 2 presenters. The first one is Raza Lam, who is the Senior Specialist of Health Policy at the Alzheimer's Association and the Alzheimer's Impact Movement. In his role, he conducts research and data analysis, drafts and designs for facts and figures sheets, and is part of the association's review team for the annual Facts and Figures report. John Sheehan is our second presenter, and he's the Associate Director of Public Health for the Alzheimer's Association. He serves as an expert on public health needs assessment and data related to Alzheimer's, caregiving, and cognitive issues. He works with health departments across the country on the Healthy Brain Initiative. He also has a master's in public health. Today is going to be all about data, statistics, and great information. On your screen right now, you will see all of our 4 states' fact sheets. I want to point out some core areas. Facts, data, statistics is really amazing. As a really amazing asset that we have when we go and work with our elected officials, both at the federal and state level. We can talk about that 69,000 people 65 and older living with Alzheimer's are in California. There's 65,000 number of caregivers in Hawaii. In Arizona, 394 million hours of unpaid care was provided to people with Alzheimer's and dementia. And in Nevada, 36.5% change in cost of care for someone with Alzheimer's between now and 2025. These are just a few facts that we can actually toss out to legislators, but you guys are going to learn a lot more, and I'm pretty sure over the years, if you've been doing this work as an advocate with the association, data and statistics is not new to you, but I'm going to hand it over to Raza to get us going with facts and figures.
Thanks, James, and hello, everyone. Thanks for joining. I'm excited to be here. I hope everyone had a good Memorial Day weekend, as good can be right now. And as James mentioned, I'm here to talk about our facts and figures. And for those of you that may not be familiar, Alzheimer's Disease Facts and Figures is the Alzheimer's Association's annual publication on statistics regarding Alzheimer's disease and dementia. It's a really comprehensive compilation of both national and state statistics and other information. And it's designed to be a statistical resource for really both researchers, but anyone who's interested in learning more about Alzheimer's and dementia. I find it, I don't have coming to the association, I had some of a stats background, but I find it really digestible. I think most people will find it digestible. And today I'm just going to share some top level facts from various sections of the report. So if we can move to the next slide, I'd like to just highlight some of the sections that I'll be going over today. First is prevalence, which is, of course, how common is Alzheimer's disease. And we're going to talk about mortality and morbidity, how many people die from Alzheimer's and dementia. Then we're going to talk about caregiving, and in this context, caregiving is, as James mentioned, we're talking about informal caregiving, that is families and friends that are providing unpaid care to their loved ones with Alzheimer's and dementia. And then we're going to talk about the use and cost of healthcare by those with Alzheimer's and dementia. And finally, we'll talk about the special report. And the special report is really unique because it's part of Facts and Figures. It's different every year. It's these really cool deep dives. And this year's is on primary care physicians and the way that dementia is treated in this country. And I find it really interesting, and I'll be excited to share that with you guys. So before I get started, on the next slide, I just want to share a quick warning from our Vice President of Advocacy, John Funderburk, who some of you may know. For those of you that have been to forum or other advocacy events, you may know that we have said this before. I'm going to be sharing so many facts and statistics today, and that when you're at an event with legislators or people from an office of a legislator, we just want you to pick a couple of stats to go with your personal story and, of course, the legislative ask. So with that warning out of the way, we can move on to the first section, prevalence. So currently this year, we project that there are 5.8 million Americans living with Alzheimer's disease, and we expect this to increase. As you can see on the next slide, we expect a 22% increase in prevalence of Alzheimer's disease just in the next 5 years, and an even bigger increase by 2050. As you'll see, it'll grow to 14 million Alzheimer's in 2050, 14 million seniors with Alzheimer's in 2050. And right now, 1 in 10 people age 65 and older has Alzheimer's dementia. So on the next slide, I've highlighted, this is a graphic I've poached that I really like, straight from Facts and Figures. And this is the increases in prevalence that we expect to see between now and 2025 in prevalence. And I've highlighted the 4 states I believe are on the call today. And we'll see that these increases are based on population projections, census population projections. We can see that the West and the Southwest are expected to experience the largest percentage increases between now and 2025. As I said on the previous slide, we expect a 22% increase nationally. So you can see that Arizona and Nevada we'll see a significantly larger than average increase in prevalence, while California and Hawaii are right on that national pace. And as you'll see later in my presentation, these increases in prevalence have associated increases with usage of healthcare system and therefore costs. So in the next slide, I'd like to talk just briefly about some gender and racial ethnic differences we see in prevalence. So almost 2/3 of Americans with Alzheimer's are women. And that translates to the lifetime risk of Alzheimer's being significantly higher for women. At age 45, lifetime risk of Alzheimer's disease for women is about 1 in 5, and for men it's only 1 in 10. And the main reason researchers think that this difference exists is because that women on average live longer. There have been a few studies in the United States that have suggested that of women and men of the same age develop Alzheimer's, that is incidence at the same rate. So that it's not necessarily any differences between men and women. It is just that women live longer. And of course, the biggest risk factor for Alzheimer's disease is age. On the other hand, certain minority groups are also more likely to develop Alzheimer's disease. African Americans are twice as likely as white Americans to have Alzheimer's disease, and Hispanic Americans are about 1.5 times as likely than whites. And research suggests here that there is a difference in the underlying incidence rates, that is that Hispanics and Blacks of the same age as whites develop Alzheimer's at a greater rate. And the research community is not entirely sure why this is, but it is believed currently the leading theory is that it is due to health conditions and socioeconomic factors. So now move on to the next section, morbidity and mortality. In 2018, which is the most recent CDC death data that we have available, more than 120,000 Americans died of Alzheimer's disease, and it was the 6th leading cause of death in the United States, 5th leading cause for those 65 and older. But on the next slide, you'll see that the picture is a little bit more complicated than just that one number will show. As I said, 122,019 people officially died from Alzheimer's disease in 2018. And if you include all forms of dementia, that more than doubles to 266,957 people in 2018. The underlying cause of death was some form of dementia, Alzheimer's or other. But population-based studies can project that the burden is actually higher than that number. Either of those numbers suggests. One study in 2010, as you can see the orange circle on the screen, suggested that 500,000 Americans in 2010 died where Alzheimer's contributed in some way to the death. Maybe not the main reason, but a reason. And each year it's projected that 700,000 seniors die with Alzheimer's disease. So again, so that official number tells a big part of the story, but not the whole story. And also another thing that we're seeing on the next slide is that Alzheimer's disease are rapidly increasing. You'll see that between 2000 and 2018, Alzheimer's deaths increased almost 150%, while other main killers you'll see in this graph remain flat or decreased, including the number one killer in the United States, heart disease, decreased almost 8% over this time period. And this increase for Alzheimer's deaths is far more than any other top 10 cause of death. The next closest is accidents with a 71% increase. In addition, it's not just that there's a bigger population and more people are dying. We're also seeing the death rate increase. In 2000, the death rate was 17.6 people deaths per 100,000 people, and in the most recent year available, 2018, it was 37.3 deaths per 100,000 people. So again, more than double. And this is really likely driven by two factors. It's driven by more Americans having Alzheimer's disease and dying from Alzheimer's disease, but it's also likely driven, at least in part, by better reporting, by better understanding that Alzheimer's does kill Americans, and that being reflected on death certificates. So with that, we can move on to the next section, which is the informal caregiving. And as James highlighted in the beginning, the value of this unpaid caregiving is just massive. We estimated that in 2019, the value of unpaid care provided by families and friends to people with Alzheimer's disease is almost $250 billion. So if we move to the next slide, you can see that, there's a $244 billion. I just want to say that's 11 times more than McDonald's revenue in 2018. And that fact always just blows my mind. And you can see it's 16 million Americans are providing that care. And also, it's not just the hours. The lifetime cost of care for a person with dementia is estimated to be over $350,000. And 70% of that cost is estimated to be borne by the family and friend caregivers in the form of both unpaid caregiving and out-of-pocket expenses. And I've also included another graph from Facts and Figures here. This graph really shows that how Alzheimer's and dementia caregiving can be different than other types of caregiving. Alzheimer's caregivers can often have to give much more extensive personal and intimate care than other caregivers due to the nature of the disease. Alzheimer's caregivers, as you can see on the graph, are almost 50% more likely to provide help with bathing or showering, and more than twice as likely to deal with incontinence. So that leads us to the next slide, where we can ask, who exactly are Alzheimer's disease caregivers? And on this slide, I've included some stats about caregivers that you can read and that I find interesting. But really what I want to highlight is that caregivers can be anyone. They're very diverse. They're often financially vulnerable. And the majority of them live in the community with their care recipient. And one other thing I want to highlight before we move on from this slide is that in addition to the majority of women, of caregivers being women, as you can see, 2/3, women are also more likely to shoulder a higher burden of care. That is, of those caregivers who provide the most care, more than 40 hours of care a week, like a full-time job of unpaid care, 75% of those are women. And on the next slide, you can see that as I was talking about the care being more personal and intimate, this directly translates to higher levels of stress. Half of dementia caregivers indicate that providing help is very stressful, and 30 to 40% of dementia caregivers report depression, which is compared to about 5 to 15% of non-caregivers, so significantly higher. And 3/4 of dementia caregivers report that they are concerned about maintaining their own health. And this is a worrying part of a larger trend that we can see about caregivers not paying attention to their own health. 34% of caregivers say that their health has worsened directly due to becoming a caregiver. And more than a fourth, 27%, said that they delayed or did not do things that were important to maintain their own health. So that's all I have on caregivers, and we can move on to use and cost of healthcare. So in 2020, the total cost from all payers of caring for people with Alzheimer's dementia, we project to be over $300 billion. On the next slide, you can see the breakdown by payer. And it's a big deal because we can see that this is the fourth consecutive year where the total payments of caring for people with Alzheimer's and other dementias will exceed $250 billion. And that's almost an incalculable number. And one study reported that the cost for a person with dementia in the last 5 years of life was 57% higher compared to individuals without dementia. And also, for those families of people with dementia, out-of-pocket costs represented a larger portion of their family wealth than compared to those without dementia, almost 3 times higher. So we can move on to the next slide. Oh, we're one behind. Can we go one more? Great, thank you. So this year, so the government really is going to spend the majority of the money caring for people with Alzheimer's disease. More than 2/3 are covered by Medicare and Medicaid. They'll spend $206 billion. Medicare and Medicaid will spend $206 billion this year caring for those with Alzheimer's and dementia. Medicare alone spends $155 billion, which is 1 in every 5 Medicare dollars is spent on someone with Alzheimer's disease. And it's not just that, again, that there are a significant number of Americans, especially seniors, on Medicare and Medicaid, but they also, due to the nature of the disease, utilize the healthcare system at a higher rate. Medicare spending is 3 times higher for someone with Alzheimer's versus someone without Alzheimer's, and Medicaid spending is more than 23 times higher. And due to the devastating nature of the disease and the costs associated with it, seniors with Alzheimer's are significantly more likely to be also on Medicaid. 27% of seniors with Alzheimer's have Medicare and Medicaid, compared to only 1 in 9, 11% of seniors without Alzheimer's. And as the prevalence of the disease increases, as I indicated earlier, we're expecting the spending also to just keep increasing. In 2050, the government will spend $777 billion in today's dollars before inflation, caring for people with Alzheimer's disease. And then that will be a projected 1 in 3 Medicare dollars. So on the next slide, I've just included a couple of snapshots of your states and the healthcare costs associated with Alzheimer's. I've included the Medicaid costs for each state, the projected increase. Again, we're seeing that with the increases in prevalence between now and 2025, and then the per capita Medicare spending. And I won't go over all these numbers, and these are on the state fact sheets, but I think these numbers are particularly interesting to me and often very helpful in our policy efforts. So moving on then to cover the last section I'm going to be covering today, the special report, as I mentioned, primary care physicians. Before I get into the results and the facts, I'd like to just cover on the next slide just briefly the study design. So the Alzheimer's Association went out into the field and we conducted a nationwide survey of current primary care physician, recent medical residents for primary care, and recent medical school graduates. And we also did some research on geriatricians that I'll also cover in a little bit. And the objective of this was really to say, we know that there's a shortage of dementia care specialists. How are primary care physicians handling this shortage? How are patients with dementia being treated? Who are they being treated by? And are the primary care physicians equipped to handle this? So in the next slide, we can see the major takeaways. And as I said, there's a shortage. A recent study projected 19% shortage of neurologists by 2025, just 5 years away. And an analysis conducted by the association in this report suggested that in order to meet the needs of the Alzheimer's population by 2050, the United States would need to increase the number of gerontologists it currently has by more than 3-fold. And as a result of the shortages now and in the future, primary care physicians report being on the front line of providing dementia care. Most primary care physicians report that there are not enough dementia specialists in their area to refer patients to. But the problem is that primary care physicians, as we see in this study, report feeling like they are not necessarily prepared to provide adequate care and guidance to people with dementia. And we can elaborate on this a little bit in the next slide. 40% report that they are never comfortable or only sometimes comfortable making a diagnosis. And 27% report that they're not even comfortable, not always comfortable answering patient questions about Alzheimer's and dementia. And in the study of residents, we see that the vast majority do not feel prepared at that point to provide dementia care. And this is really a worrying trend, and one that we're hoping as an association to address. So on the next slide, you'll see, and James had highlighted them earlier, these are the state fact sheets. I won't go over every state on those. They're fun to explore on your own, but I will say that every stat on here, except that purple box all the way down at the bottom, that's for your state. That is an individual state statistic on mortality, on prevalence, on costs, on caregiving. And I just want to quickly highlight a new statistic for just this year from the special report, and that is in your state, the number of geriatricians currently in your state and the percent increase needed that I was mentioning to meet the needs of the Alzheimer's population by 2050. And for almost every state, this is just an insanely large increase. So with that, that's really all the facts I have for you today. But like I said, this is a huge report. A lot of effort goes into producing it. If you're hungry for more, I really recommend checking out alz.org/facts. The full report is available for free for download in PDF. And all the individual state fact sheets are there. If you want to download your own, if you want to send your family and friends in other states their fact sheets, there's a world of possibilities. And if you found this stuff interesting, there's really just tons and tons and tons more that I couldn't cover today. So please go check that out if you're interested. And with that, that concludes my presentation. I think we have some time to take some questions. Susan?
Yes. Go ahead, Susan.
Oh, great. Raza, thank you so much. What a way to blow through that document and point out the most important pieces for us to highlight. We had two questions in the chat while you were talking. The first came from Jenny Roth. She's wondering what the difference between dying with Alzheimer's and dying from Alzheimer's.
So that's a great question. And unfortunately, it is somewhat intangible, but we know that when death certificates are recorded by physicians, Alzheimer's didn't used to be the cause of death. Even though it was due to Alzheimer's, it would be in the hospital because of pneumonia or heart failure or something else. And now we are getting better, as I was saying, at recording those causes of death as being dementia, which they are, rightfully are. But that number of Americans dying with Alzheimer's just indicates how many seniors have it. So we don't think that it may not necessarily contribute to the cause of death in those cases, but it definitely, as we know, contributes to quality of life. Does that make sense?
That does make sense. Thank you. Our next question is from Michael Silva, and he asks, is there any data to show whether or not the level of quality care is proportional to the cost of care?
I'm not sure on that one. That's a good question. I've not seen any, but that doesn't necessarily mean that it's not out there.
Okay. And Mark White asks, is the sample, oops, there's my dog. Is the sample of doctors sufficient to project the need for additional doctors?
So that's a good question. So the way that we projected this need is that we looked at the number of Americans we project to have Alzheimer's disease in 2050 using those census projections and incidence rates. And we then use guidelines from the AMA on how many patients doctors can manage on their schedule. And we say, if we wanted Alzheimer's patients to be served by these doctors, then how many would we need based on the number of people with Alzheimer's disease and those AMA guidelines?
Excellent. We have a repeat question or a follow-up question. If Alzheimer's is not the cause of death, is it fair to say that if the other disease had not killed the person, they would have died of Alzheimer's?
It's hard to say on an individual case because we can't know that it wouldn't have been something else that would have killed them in addition to Alzheimer's. But we can say that Alzheimer's is a fatal disease. There's no recovering from Alzheimer's. Alzheimer's is always eventually fatal.
Okay, that's a good, not a good way to phrase it, but it's an accurate way to phrase it. And so, Raza, just so you know, we have about 72 people on the line, and they're from all 4 states. And lots of people are showing their thanks to you for this great data and the walkthrough. And now I turn it back to James.
Thank you, Roz and Susan, and everybody who's on the call and is asking questions. I did not say this at the beginning of the presentation, but if you do have questions, please put it in the chat, not the Q&A. And right now, we will turn it over to John Sheehan.
Excellent. Thank you so much, and hello, everyone. As James said, I'm John Sheehan. I'm the Associate Director of Public Health for the Alzheimer's Association. I'm based here in Washington, D.C., so hello from the opposite side of the country. Today, I'm going to be talking about data collection. And so I think we can go forward to at least the objectives, James. And I just wanted to repeat what James just said. I'm going to be going through a lot of technical things, a lot of technicalities. You're going to see some numbers from the data source that I'm talking about today too. So I do want to encourage everyone to ask a question if you need more info. If you have just it's piqued your interest, I'm happy to answer questions at the end today. So as you can see, we have 3 objectives for today. And on the next slide, I'm going to dive right into our first one, introduction to surveillance. So what is surveillance? And this is, I think most people on the line have heard of surveillance. We think about, security cameras up in the corner, maybe hacking in the background or something along those lines, which is true. That's how one industry uses the word. But when I talk about surveillance, it's really about data collection. So surveillance is the science of observing, recording, and collecting data. It's one of the ways that we, after we analyze it and after we look at the results, it's one of the ways that we determine kind of at a population level, so across a state or across a county, across a city, one of the ways that we determine where do we need to focus our energy, where do we need to focus our attention. One of the big things that we're going to talk about today is impact and burden, which I think we can actually see on the next slide here. Impact and burden is, it's essential for our decision makers out there to kind of understand what we as the Alzheimer's Association, or really any group out there, what we are trying to persuade him or her to do. Surveillance and data collection, it's an essential service of public health, which is why I, from our public health department, am talking about it. And it is that process, the science of collecting and observing, reporting on data, so that we better understand kind of what health problems exist in a population and what we might be able to do about them. The Griffis that you see at the bottom of your screen right there stands for the Behavioral Risk Factor Surveillance System. And Griffis is what I'm going to be talking about today, but it's just one mode of surveillance. It's one surveillance tool. The census is another really common, really prevalent surveillance tool. But surveillance happens all the time. It happens at the county level, it happens at the state level. There's a lot of different local data sources that go into surveillance that kind of helps the public health agency, for instance, kind of keep track of the well-being, the health of a population, and know what issues are affecting that specific population as compared with other populations. And that's really where the power of data collection and the power of surveillance comes in. So one thing to understand about surveillance and about data collection is it tells us kind of how big a problem is. So for instance, how many people in California have diabetes? How many people in Hawaii have heart disease? It just tells us a number. It helps us kind of extrapolate and tell how big a specific problem is. But if I were to tell you that 200 million Americans every year suffer the same injury, you might say, whoa, that's a huge number, which it is. It's nearly every American adult. And you might say, like, oh, wow, we really need to do something about that. It's affecting like 2 out of 3 people across America. We need to be shoving money at it, solve this problem. But the other aspect to surveillance that is important, it tells us not only how big a problem is, but how severe it is, or what the impact is, what the burden is. And so back to that 200 million American example, that injury I mentioned is actually paper cuts. So paper cuts are terrible. Everyone hates them. If I could get rid of them, I would. But do I really want my tax dollars, or do I really want our research funding going to paper cut prevention or paper cut services and supports? Not when it can be going to larger impact, larger burden issues like diabetes, like heart disease, and of course, like Alzheimer's and dementia. And so that's where surveillance comes in, and that's why it's such an integral part to what we do here at the association, and specifically out of the public policy division. It tells us how big our issue is and how burdensome, how severe it is for the people that have to endure it. So on the next slide, I'm going to walk through just really quickly what Griffis is. So Griffis, the Behavioral Risk Factor Surveillance System, it's an annual telephone-based survey. There may be a handful of you on the line who have participated in previous years, but it's asked every year in every state, as well as all of our territories. And it's the main way that states kind of track and keep track of health conditions and health problems within their population. On the right-hand side, you can see examples of the kinds of data that are collected. These are general things about demographics. So what is your age? What is your weight? What's your income level? What is your education level? General demographics to understand who is living in the state. It also asks then about health conditions. So these are mostly history of chronic diseases. So have you ever been diagnosed with heart disease? Have you ever had a stroke? Have you been diagnosed with diabetes or depression? Have you ever had cancer or have arthritis? And so it lets the state know how many chronic conditions and health conditions, how many people within the state actually have them, as well as asking that third category at the bottom about risk behaviors. So these are things like, are you currently a smoker, or have you ever smoked? How often do you smoke? How often do you drink? How many drinks on average are you consuming? How much physical activity do you get? When was the last time you went to go see a doctor? And if you didn't go see a doctor, how come you didn't see a doctor? And so it's a very quick, I shouldn't say very quick, because I'm sure it's long for some individuals, but it's usually about a 20 to 25 minute long phone interview survey. And it covers these kind of very broad-based demographics, health conditions, and risk behaviors, give us an annual snapshot of the health within a population in a given year. So on the next slide, we'll see kind of the 3 main components of Griffis. So Griffis it's a collaboration between the State Department of Health and the federal CDC, the Centers for Disease Control and Prevention. And like I said, it's asked every year. In that first bucket, the core questionnaire, this is where those demographics, those health conditions, and those risk behaviors are at. So these are asked, they're asked either every year or every other year, and they're asked in the same way so that we get to see kind of trends over time. So have you ever been diagnosed with diabetes? That question has appeared, I think, for the past 20 years or so on Griffis. And so we get to see over the past 20 years, what is the diabetes rate within a state over that time period. The second component, the second bucket of Griffis are what's called state-added questions. And this is the state kind of determines if they have a particular health concern that they're interested in learning more about for their population, they can add additional questions to their survey to find out more information about them. So common examples of this were on like opioid use or opioid prescriptions a couple of years ago. I know a lot of states right now are looking to asking about COVID. So did you receive a COVID-19 diagnostic test? What was the result of that test? How often did you get that test? Those are kinds of questions that states just, they themselves need to know what that information is, and so they've added those questions to the survey. And then the final bucket on the right-hand side are what are called optional modules. This is where I'm going to talk about the majority of my talk today. Optional modules they're kind of a set of predetermined questions on a given health topic. So today we're going to be talking about the cognitive decline module, and we're going to be talking about the caregiver module. And let me just go ahead and dive right into that first one. On the next slide, we'll see the caregiver module. And you might ask yourself, cognitive decline, I have an idea of what that means. Oh, if we can go back just one, we'll get back to the cognitive decline module. First thing to know about it is it's a set of 6 questions that a state may add to their Griffis survey, and I'll talk about why we do that in just a minute. But the cognitive decline module asks about subjective cognitive decline. It measures subjective cognitive decline, which we call SCD. You can easily ask yourself, what does SCD mean? Not a lot of people know what that means. But the important thing to know is that SCD is a self-reported measure. It's an increase in memory loss or confusion. And so let me just pause real quick and kind of rephrase that, because it is very important to understand how what SCD is and why it's an important metric for us at the association. So if I'm answering the survey and I was asked this question, if I was experiencing, over the past 12 months, my memory has gotten worse, or I am getting more confused than I used to, I would be said to be experiencing subjective cognitive decline. So it is not a diagnosis, it is not dementia, but is actually one of the earliest warning signs of dementia. And when we step back and think about it, it does make sense, because I myself may notice a change in my own thinking or my own memory that hasn't been prominent enough or pronounced enough for those around me to notice. I may think, I used to be quicker, or I used to not have as many struggles with recalling objects or recalling names that I used to. And so it's a really good indicator. It's one of the earliest warning signs of future dementia. And it's also, if you are experiencing subjective cognitive decline, it's actually a risk factor for later developing dementia. I do want to say that not everyone, and in fact, the majority of people that have experienced subjective cognitive decline, they do not go on to develop dementia. But everyone that does develop dementia has experienced subjective cognitive decline at one point. And so, again, it's one of the ways that we at the association, particularly through our public health focus, one of the ways that we try to encourage early detection and diagnosis. If you're experiencing these cognitive decline issues, go and talk to a healthcare provider about those cognitive issues so that we may be able to do some diagnostic testing and see what happens if some medication has changed, if diet has changed, or what your options might be on an individual basis. So the cognitive decline module measures SCD, and then it also measures potential difficulties that SCD can cause with everyday activities. So is it interfering with your ability to do household chores? Is it interfering with your ability to go to work or to volunteer as you used to? And the last question that it asks about is whether or not you've had that discussion with a healthcare provider. If you're feeling this way, if you're noticing this change in your memory, or you're noticing this increase in confusion, have you talked to a healthcare provider about it? So that's the cognitive decline module. We're going to get into some data in just a minute. Before we do that, I'm going to go to the next slide and talk about the caregiver module, which of course identifies caregivers. So the caregivers, as Griffis defines them, are, as you can see on your screen, those who provide regular care or assistance to another person due to a health problem or disability. So the key aspect to know there is that this would exclude like parents caring for their kids, grandparents caring for their grandchildren, unless that kid or grandchild has a health condition or a disability that requires additional care. So it is really for those problems that require additional assistance, like stroke, HIV/AIDS, and of course dementia. The caregiver module identifies caregivers. It measures the length of time and the intensity that they've been providing care to that individual. And it also outlines what their actual duties are. So are they helping with those household activities like feeding, like bathing, like dressing? I'm sorry, those are personal care issues. Are they helping with household duties like cooking, like cleaning, picking things up from the store. So it gives us an idea of that length in time, that length in duration, gives us an idea of burden, and the caregiving duties also comes in and gives us an idea of just how, what those caregiving duties are, how burdensome they may be for an individual. So let's go to the next slide and figure out, what did the data actually say? What have we learned from the cognitive decline module and the caregiver module of the behavioral risk factor surveillance system? The next slide, we're going to first talk about the cognitive decline module. And so this is from a nationwide, this is kind of our nationwide data. Looking at all 50 states, we know that 1 in 9 people aged 45 and older are experiencing subjective cognitive decline. So that's almost 12% of people aged 45 and older, which is the cutoff age for the cognitive decline module. Almost 12% of Americans nationally are experiencing that increased confusion or that worsening memory loss. And so that's just a really heavy statistic for thinking about kind of how big this problem is. We know that memory problems, even if those individuals do not go on to develop dementia, as most of them will not, those cognitive issues can interrupt social relationships. They can interrupt chronic disease management. You know, if you think about it, if you're having trouble with your memory, it's not as good as it used to be. You may not remember, did you take your medication before? You may take it twice. You may forget to take it that day. And so subjective cognitive decline in and of itself is definitely a health condition that we can address from some large-scale public health interventions. We also know from the cognitive decline module that less than half of those individuals with SCD have discussed the problem with their healthcare provider. So 12% of the population are experiencing this. Only 6% of that of Americans with this have actually gone and talked to their healthcare provider about it. And that's a huge number that we really want to get that number all the way up to 100%. So that if you are experiencing subjective cognitive decline, you know that there are options, there are potential ways that cognitive issues may manifest outside of dementia. But if it is dementia or an early warning sign of dementia, that early detection and diagnosis is so essential to accessing services, accessing supports, really allowing an individual that does develop dementia to live with as much cognitive ability intact for as long as possible. So increasing early detection and diagnosis is one of the best ways that we use that middle data point there. And the last one that I'm going to talk about from the cognitive decline module is we know that SCD is interfering in 1 in 3 individuals with their ability to work or volunteer or engage socially. So again, even though SCD, again, it's not dementia, it is not a diagnosis, but it's already interrupting people's lives. They're finding that their memory loss or their confusion is burdensome enough that it does interrupt that ability to work or volunteer or engage socially. On the next slide, some brief caregiver statistics as they slowly come through here. There we go. I'm sure I don't need to tell anyone on today's presentation this, but from the data, we do know and we can point to the fact that dementia caregiving is long, it's intense, and it's personal. From the caregiver module of Griffis, we know that over half of dementia caregivers have been providing care for at least 2 years. 2 years and often all the way up to 5 years. Over half of them are doing it for that length of time. Among dementia caregivers, nearly 1/3 of them are providing 20 or more hours of care per week. And we know that 3 out of 5 help with those really personal care responsibilities like bathing, like eating, going to the bathroom, and getting dressed. And so from the caregiver module, we know that across a population, what individual dementia caregivers know all too well, but we know across a population that it is really long, it is really intense, and it is really personal. So those are some quick highlights. On our next slide, I want to go into some individual state data points. And I know we're getting near the top of the hour, so I'll make sure that I give enough time and attention to these, but not so much detail that it takes all the rest of our time. So here I just pulled 2 data points from our cognitive decline module. How many people in each state are reporting subjective cognitive decline, and then how many of those with subjective cognitive decline have talked to a healthcare provider about it. And so here we can see the spread. Before I said it was about 12% nationally, but we see individually for Hawaii, for example, is one of our lowest prevalences of subjective cognitive decline at 8.9%. Nevada actually has one of our highest at 16.3%. And so there is definite variability that we see state to state. And this just helps when we go in with our individual state-based statistics, when we're going to, and talking to legislators, when we're talking to agency officials or our governor, knowing the state-specific issue and the state-specific burden really helps illuminate and bring attention to the issue for our neighbors, for our friends, for our family members that live in the state. So here we see the spread of those living with SCD, but we also see the spread of how many of those individuals are talking to their healthcare providers about it. And so just to point out, while Hawaii may have one of the lowest prevalences of subjective cognitive decline, we know that more of them, or I should say fewer of them, are talking to their healthcare provider about it. Only about less than 40% have actually talked to it. 62% of them have not talked to a healthcare provider about it. And so that spread really indicates that we need to increase early detection and diagnosis efforts. We need to increase public awareness education campaigns about subjective cognitive decline, and when changes in memory or when changes in cognition do warrant a conversation with a healthcare provider. So those are just some very quick statistics on the cognitive decline module. The next slide will walk us through some brief statistics on the caregiver module. And here I actually want to pause and point to that California column real briefly, because I say that it's not applicable, which is untrue. We know that there's a ton of dementia caregivers in California, but this really speaks to the power of your stories as advocates. Because on the data side, when California last included the caregiver module, through kind of statistical anomalies, the number of dementia caregivers that responded to the survey just wasn't big enough for us to get reliable statistics from. Excuse me. It's not to say that there aren't dementia caregivers in California. Of course, we know that there are, but just kind of through that data collection process, it's imperfect. We didn't collect a large enough sample size in order to do reliable statistics from it. And so this is just while data is super important for kind of explaining the large scale impact and burden that our issues have to a legislator, to a governor, it doesn't replace and could never replace the personal stories that you as advocates bring to those conversations. And so this instance with California is just another example, or it's a great example of why that advocacy is such a huge component of our public policy work. But for the states that did have large enough sample sizes of dementia caregivers, we can see that there is relative similarity between the states for how many have been providing care for 2 or more years. And we see similar levels for those that are providing 20 or more hours of care per week, but we do see a little bit of a spread. And so in Hawaii, for instance, it's one of the lower numbers across the country. And this may just indicate that even though we know that nearly 60% of them have been providing care for 2 or more years, only 40% of them have been provide 20 or more hours of care per week. And this just may suggest that there are many dementia caregivers for a particular individual with dementia. And so the more caregivers that are chipping in and providing care, the less average hours per week for each individual dementia caregiver. That may indicate intergenerational households, or it may just indicate additional help that's outside of those dementia caregivers. So on the next slide, I think is and I'm nearing the end here, so I'll be happy to take questions. But how do we at the association actually use this data? So if we go ahead, one more slide here. The big thing that hopefully you've seen some of these fact sheets. If you've been with us for a while and have attended a state advocacy day, These fact sheets are just vitally important to kind of really help make the case on cognitive issues and on caregiving issues within the state. So we kind of take all of these broad, sometimes I call it mumbo jumbo, these really huge data statistics, boil them down into simple data bites so that we can easily digest and talk about our cognitive concerns and our caregiving concerns, producing these fact sheets and these infographics. And on the next slide, we'll see that the reason that we do all of this and the reason that we spend so much time on data and data collection, data analysis, is we know that data does really drive public policy and public health priorities. So we use the facts and figures data that Rosa presented on. We use the Griffis data that we collect on an individual state basis, as well as lots of other data sources to educate our policymakers, our decision makers, our healthcare providers about these cognitive concerns, about these caregiving concerns, so that they themselves can do their job better. Whether that's setting legislative priorities, whether that's setting executive priorities, or whether it's an individual healthcare provider, just understanding how prevalent subjective cognitive decline can be, for instance, that he or she should be asking their patient population about memory concerns on a regular basis. Data really helps us advance Alzheimer's as a public health issue, just kind of advancing the broad-based population approach that we need in order to address these issues. And the way that I like to phrase it is in that purple box there, where the cognitive decline module data, the subjective cognitive decline, it really tells us the prevalence of SCD outlines what the burden may be, what the burden of dementia may be tomorrow. Again, it's not dementia, it's not a diagnosis, but it is that indicator of future dementia risk. And so that's why we need to be paying attention, and we need to be enacting services and supports today so that we can anticipate and respond to that burden tomorrow. On the flip side, the caregiver data tells us what the burden of dementia caregiving, how long, how intense, how personal it is, what that burden is today, so that we can beef up, and we need those services and supports issued out today to help us support our friends, our loved ones, our neighbors who are caring for a loved one with dementia. And I think my final slide is time for question and answer. So Susan, I'd be happy to answer any questions with the little bit of time we have left.
John, thank you so much. That was excellent. And we did have two questions we couldn't answer in the chat. A couple of people asked about, is there any link to brain health registries and the BRFSS, Griffis survey?
Good question. So there are not. So brain health registries, or kind of Alzheimer's and dementia registries, are a separate registry entirely. It's a whole different infrastructure that is separate from the Griffis system. Yeah.
Okay.
Unfortunately. Yep.
And then another question is, when you talked about gathering demographic data, does that also include information on gender and sexual orientation? Do you know if those questions are asked routinely?
Yeah, so gender is routinely asked, or is routinely collected each year. It's one of the core questionnaire surveys. Sexual orientation and gender identity is actually, yes. That is an optional module. And there's a big push kind of within Griffis coordinators and kind of within data collection circles. There is a big push for that. It's called SOGI, Sexual Orientation, Gender Identity, for that optional module to become a core component. It is not yet, but a lot of states do routinely include SOGI in their Griffis survey. So they do get that data, but it's not every year, and it's not every state yet.
And John, could you elaborate a little bit on the SOGI data? So it would be a separate optional module, or it would be overlaid on the two optional modules that we conduct?
Good question. So it is a separate optional module. And this one thing that I didn't say is a state can add as many optional modules as it would like. Often there's a limit for time or for funding, because with the more questions you add, the longer it takes to do the survey, which means you need more people to ask the survey and dial all the phone numbers. So there's usually a limit to how many they add, but they can add as many optional modules as they would like. And the SOGI module is a wholly additional module, so it asks about what is your sexual orientation, how do you identify your gender, and then those questions, those responses, the great thing about Griffis is you can, it's called cross-tabbing. So you can find out how many women are responding to this particular question, how many gay individuals are responding, have diabetes, how many men report subjective cognitive decline, how many gender minorities are say that they have had a stroke in the past year. And so we can use those optional modules and that data and cross-tab across all questions of Griffis in order to understand the health and the health of individuals within the state.
Excellent. Thank you. That's all I've got, James, from the queue, other than a lot of appreciation being expressed to both of our presenters.
Thank you both, Raza and John, for presenting today. If you would like to contact them, you will see their contact information on your screen. You can also reach out to your public policy staffer for their contact information. This has been a great presentation. I do want everybody to know that all of the policy staff, we had a meeting on Monday, and we decided that next week's presentation, we are actually going to go on summer break for a week. So the Alzheimer's Impact Movement is going to be pushed back to June 10th, and we will go through the end of the month. So next week, you guys all have a free week, which is great and exciting. I do also want to let everybody know, please check your email today. You should have received an email from the Alzheimer's Impact Movement. Today is a day of action. We are asking our members of Congress to co-sponsor the Promoting Alzheimer's Awareness to Prevent Elder Abuse Act. So we hope everybody participates in that. If you did not receive the email, please reach out to your policy staff designee. And we look forward to seeing everybody on June 10th. Thank you, everyone.
Thank you, James.